Our next speaker is Swapnil Shrivastava from Data Science Department. She'll be speaking about big data security and privacy for enterprise service ecosystem in Indian healthcare scenario.
Good evening, everyone, and I'm the 5th semester PhD student here, and I'm my research supervisor and is Professor T.K. Shrikant. And here is the agenda. I'll first give an overview of what is enterprise service ecosystem, and then we'll move to different facets of current Indian healthcare scenario. The current these different phases, they have led to this next generation healthcare ecosystem, and we have proposed a security and privacy framework. So we will briefly see what are the salient features, and here I'll talk about just a few challenges, but there are many challenges which we need to address to make the next generation healthcare ecosystem secure and privacy preserving. So what is enterprise service ecosystem? So this we had defined in one of our previous work, where we came up with a big data analytics framework for enterprise service ecosystem in an e-governance scenario. And so enterprise service ecosystem, basically, it is developed by modularizing and bundling of functionalities or business rules in the form of services. Now these services, they are loosely coupled, they are heterogeneous, they are distributed, and they kind of they work in an orchestrated manner, and they orchestrate among themselves in a seamless manner. So that is how they work. And Aadhaar authentication ecosystem is one example of enterprise service ecosystem, where we have components like Aadhaar holder, authentication device, sub AUA, AUA, ASA, and then the authentication server. So when an authentication request is sent from an authentication device, so the device will capture the personal identifiable details of the Aadhaar holder. Those details, they will be converted, packed as a PID block and sent to AUA. AUA are the ones who provide Aadhaar enabled services. AUA will send the request to ASA, which provides a secure connectivity to CIDR, and auth server will do the authentication and send back yes and or no to the same channel back to the authentication device. So here each and every component, they perform a particular function, and they kind of log the event data based on the function performed by that component. Now the observation here is, if we analyze a particular component, the information that we get, that information cannot tell us how this orchestration of services, it has an impact on the overall ecosystem, that we cannot get. And a similar observation was made in an IIIE intelligence system article, where they said that there is a need for novel big data analytics framework for enterprise service ecosystem, and we came up with a big data analytics framework which was based on a bottom-up approach. So at each component, they store event data, which is the log data. And what this framework did is, it would construct a local structure, and these local structures were then proliferated into a global structure. This is how we performed the analytics in a bottom-up approach. And there were different users in Aadhaar authentication ecosystem, so we took that as a case study. So now this comprehensive view of the ecosystem that we got from the framework. So the different users are, say, Aadhaar holder. He got the information on, how much is the request processing time. Now AUA ASA, they are more concerned about, is there any business rule violation, or they are interested in process discovery or performance analysis. And authentication service provider, that is the CIDR, they are interested not only in performance, but they are also interested to detect malicious behavior in the ecosystem. Now coming to the different facets of Indian health care scenario, here are the three facets. There has been technological advancements. Now if we see the healthcare service providers, they have automated systems, and they are capturing they are storing the data in a digital form based on the service provided by them. So now we have wide variety of data which is being captured, electronic medical records, laboratory data, radiology reports, DNA samples, and now we have continuous data also coming in from fitness devices and health sensors. Societal perspective, there is an inequity in health outcome which has been reported in in the national health policy. Then there is a mobility of population from rural to urban area and from one city to another city. There is also inequity in access to medical facilities. All the facilities are not available in rural area, and there is huge health care cost which is kind of pushing many people below the poverty line. Then there is considering all these these observations, government, they came up with national health policy, and the goal of this policy is to bring a fundamental transformation in healthcare sector, or the way the healthcare service providers are providing these services, in a way that it kinds of make the services cost effective, efficient, and in a way there is a high impact of the way things will be done in the future. And in line with this goal, government came up with EHR standards for India, then Digital Information Security Healthcare Act, where health information exchange and clinical establishments, their roles have been defined, and how they will store the data, collect the data, transfer the data. Those standards and regulations have been defined in this act. Then Ayushman Bharat Yojana, and the National Health Stack, which is kind of an approach document which is about how this Yojana should be implemented. And other than that, there have been digitization of public health programs. Many programs are there, like the mother-child care or mental health programs which are there. So these facets which are there in the current Indian healthcare scenario, they kind of became the background and motivation for our work. And if we see today in India, the data is in silos. All the healthcare service providers, their data is in silos. There is no interoperability between them, and the patient doesn't have access to the data. So to come up with a major transformation in line with the national health policy, there is a need to come up with a comprehensive view of the patient records which are stored as fragments with various healthcare service provider, that is required. And what is suggested is, if we have such a comprehensive view, then such comprehensive view will result in cost effective treatment. It will ease out the creation to find the medical history of a patient, and it will also help in providing quality care for the patient. So the next generation healthcare system is envisaged to be a ecosystem, which we defined earlier. So here the components, this next generation healthcare ecosystem components are clinical establishments, health information exchange, and the health information systems. So clinical establishments are, say, this laboratories, clinics, hospitals. Health information exchange is introduced which connects one clinical establishment to another, and it also connects to other HIE. Now, these HIEs, the number of HIEs which will be there, it's still not, we are not clear about it. Now, if it is, whether it will be region-wise or it would be state-wise. And the health information system is the one which will capture details about clinical establishments or details related to disease. So, it is basically for analytics tasks, which the researchers or the public health officers, they would be interested in. So this next generation healthcare ecosystem, it should be distributed, it should be scalable, heterogeneous, aggregated, dynamically interconnected, and patient centric. And this is based on the requirements that we gathered from various government initiatives. Now, it has also been observed that the developed countries who have EHR systems, the data breaches after the adoption of EHR has taken an upward swing because the data is electronically available. And also it has been observed that these breaches are not by the external entity, but it is because of the unauthorized access on the data or the unauthorized disclosure of the data. Similar report has been, last year there was a report in India as well of a ransomware attack on one hospital in Mumbai. Then there are various papers which have brought out the concern that the current security and privacy measures, they are inadequate for the health data. And hence we have proposed a security and privacy framework, and these are the salient features of the framework. We are, the draft is ready and we are yet to submit it for publication. So there is consent based access control and data integrity at the clinical establishment level. Then there is a need for identity management, data breach detection, consent management at the HIE level. And before the data is sent to HIS for analytics, the privacy preservation techniques are applied on that data. Yeah, and one more thing, here we have introduced two more components, which are patient portal and health service directory. This is patient portal will provide, will help the patient to view his health records, give consent, and also to track who from where has accessed the records. And health service directory, it is kind of a directory, it is a repository of all the clinical establishments which are there. Now these are not only the features, but there are a lot of challenges which we need to address to implement these features. And so here we'll discuss two, which is one is consent management. There are many many countries, they have health data privacy legislations. HIPAA is there. Then New Zealand have their own health privacy legislations. But the healthcare solutions, these legislations are not implemented into the healthcare solutions. So it has been observed that there is a gap between the legislations and the healthcare solution, implementations of those privacy policies in the healthcare solutions. For example, Australian government, they have come up with a national health information network, which is My Health Record, and they also have consent, purpose, informed consent in their Privacy Act, but this system provides implicit consent. So by default, it is opt-out because there was a low adoption for the system. So the default, they have set the consent as opt-out. So by default, everybody are there in the system, so they have to opt out. Then there is one more example for data sharing. As per US privacy law, an explicit consent is required before data sharing, but it seems Google DeepMind, the Royal Free London NHS Foundation Trust, they have shared the patient data without taking the explicit consent from them, and they have shared it with Google DeepMind for coming up with an app for kidney injury, to generate alerts for kidney injury. So now we have Disha with us, which also talks about consent, consent from the patient, and they also state that patient is the owner of the data set, and the patient should have the access, should have the rights to grant and revoke the consent. So we will be, in this work, we will be addressing this challenge. So the patient, other legislations also empower the patient to provide and revoke the consent, and they should be informed about the uses of their data. So what is needed and what we are going to address is to get and manage consent in a granular. As of now, either you accept or reject, it's 1 or 0. So the consent has to be granular, revocable, and transparent manner. That is, the patient should know who has accessed his health records. Okay, so this is about consent, gathering consents. Now, most of the healthcare solutions, the authorization is generic, means everybody has the access to the data, and that is the reason for so many healthcare breaches that we hear about. Then the conventional access control mechanisms, they are built in some of the systems, but they cannot take care of privacy policies because they are all about user, role, and the resource, that the permissions on the resources. So hence there is a need for dynamic consent based access control, which is based on patient's privacy requirement, and it should also abide to the legislation. For example, only, so this is an example of granular consent, that only the general physician whom the patient consulted and gave consent should get access to patient's record and not anyone else. Now it should be dynamically handled, it should dynamically handle remote consent, because ours is a distributed system. Say a patient having his record in hospital A, and now he has gone for to seek second opinion in hospital B. So now here there is a need for remote consent to be sent to hospital A. Please send my records for second opinion to hospital B. So there is a need for remote consent and exceptional cases, and these have to be done in non-forgeable and non-repudiable manner. Now mostly in the access control in healthcare, they consider patients, physicians, nurses, but there is a need in this ecosystem to consider other stakeholders as well, like insurance companies, government organizations, researchers, and government bodies. So here are the two of the many challenges that I'll be addressing in the PhD work here, and I think more than Q&A, I should ask for suggestions. Thank you.